Oh,
Let me hit. All right, so we'll hit record and then I'll let you take over whenever you're ready. Thank you
thank
for your
you.
time.
No, thank you very much for the warm welcome. This is one of my favorite talks to give every year, and I thank you, Sue, for even at my interview, you were one of the people who like kind of understood what my goal was to kind of put these two fields together, and so I always appreciated that. And so we're going to go into some depth about trying to teach you guys a little bit of rheumatology. Let me see if I can try to share my screen. Um, I think it's going to be this one. And then, can you guys see my
Yep,
screen?
we're good.
Oh, all right, perfect. So, the point of this talk is to really give you guys some idea of some recognition of our rheumatic conditions, not necessarily to turn you into a rheumatologist, but the reason I really like putting these two things together is by far the most common thing we see in rheumatology are musculoskeletal complaints, similar to sports medicine. So, not necessarily that you need to know how to treat these conditions, but you at least need to know how to recognize these conditions when sussing them out compared to our traditional sports medicine injuries. So I have no conflicts of interest and no financial relationships with any companies that pertain to this talk. And so today we're going to sort of discuss various rheumatic conditions. We're going to spend a lot of our time mostly focused on arthritis, differentiating between inflammatory and degenerative arthritis. We are going to pepper in some rheumatic conditions towards the end, just for recognition's sake. And throughout, we're going to talk about some of the physical exam findings, the labs you might see that might pertain to these conditions, and some of the imaging as well. And then additionally, we'll review some of the treatment plans. Like I said, I'm not here to turn you into a rheumatologist, but at least that way you're at least somewhat, you somewhat recognize what we do in rheumatology. So these are some of the topics. We'll split arthritis into mechanical and inflammatory. We'll talk about some of the rheumatic conditions. Towards the end, we'll also spend a minute on therapeutic use exemption for our athletes, and then we'll also spend a couple of minutes on vaccination updates. And so before we're talking about anything else, we got to talk about what rheumatology is. My favorite quote from my PD at Stony Brook was, what is rheumatology? And the way he would describe it, it would be as interventional immunology. And I think that is a really, really really wonderful and concise definition of what we do in rheumatology. So to sort of simplify what the immune system is, we split it up into two different types. The innate immune system, which is what we're born with, which is very primitive and sort of is very, very fast acting and is triggered by pattern recognition. This is where we see a lot of the neutrophils and the macrophages and dendritic cells all sort of congregate toward an area of injury. And then we have the adaptive immune system, is what we develop later and throughout our lifetime when we're exposed to an antigen. This is what's going to create our killer T cells and memory B cells. So that way, if we're exposed again, we have antibodies and it can potentially prevent disease from reoccurring. So when we have issues with these different types of immunity, these can lead to different types of diseases. With our innate immune system, when you have a dysfunction here, you develop one of these autoinflammatory diseases. Think of like familial Mediterranean fever or some of our periodic fever syndromes, whereas the adaptive immune system really causes true autoimmune disease, where you develop autoantibodies that have lost tolerance to self. And these are the things that you think of like rheumatoid arthritis and lupus, where you have antibodies that actually trigger the inflammatory cascade and cause damage. So talking about arthritis first, there are over 100 different types of arthritis. And about 20 to 25% of patients will be diagnosed with arthritis at some point. When it comes to the knee, about 45% of patients will have a lifetime risk of developing symptomatic knee OA. And by far, the most common type of arthritis is osteoarthritis. 1 in 7 adults will probably develop it at some point in their lives, and this is associated with as we get older, people who get heavier, if we have a previous injury to the area, those with chronic disease, and really that's sort of secondary to the sedentary lifestyle from chronic disease, and those who have disability are more likely to develop OA. That accounts for probably about 75% of all arthritis. Rheumatoid arthritis is the second most common cause and accounts for probably about 20%, but really affects about 1% of all adults above the age of 35. But when we talk about arthritis, it's not just the physical manifestations of arthritis and the clinical manifestations that bother us. It's also there's a huge economic burden. to arthritis, and it affects about 1% of the U.S. gross domestic product is spent on arthritis in some way, whether that is the treatment of arthritis, whether that is lost wages. This is very much an economic issue, not just a clinical one that we'll see in our daily lives. And so when we talk about arthritis, we like to try to split this up. This is sort of the global term here. We can differentiate between degenerative and inflammatory. With degenerative, we think of that osteoarthritis. But if we break inflammatory down, we can see that there are classic connective tissue diseases that can cause inflammatory arthritis, where things like lupus and Sjogren's and vasculitis, where inflammatory arthritis is not the predominant issue, but it can be a feature of the disease. Then we have the more the primary inflammatory arthritis like rheumatoid arthritis, which can be split up into seronegative and seropositive. And what this means is that do you have the antibodies that are associated with this, the rheumatoid factor and the citrullonated acyclic citrullonated peptide, the CCP antibody. Those with positive antibodies typically have a more aggressive course of the disease. Then you have the crystal arthropathies. There are many different types of crystal arthropathies, but the ones that are pathologic that we see the most in our clinics are gout and pseudogout, uric acid crystals and the calcium pyrophosphate crystals. And then you have the seronegative spondyloarthropathies that you can split even further into, the axial spondyloarthropathies, psoriatic arthritis, reactive arthritis, and then inflammatory bowel disease related arthritis. So let's look at osteoarthritis and see what is the primary driver of the development of osteoarthritis. It's really the hyaline cartilage that sort of loosens, and this could be caused by a direct injury to the area, maximal loading because of a heavier weight, and then those who are develop it from chronic friction, those from repetitive use. And what happens is that you actually degrade the collagen in that area. It causes a pro-inflammatory cascade and activation of cytokines. Metalloproteinases go in and start to eat up some of the cartilage. The cartilage dies off, and then you have bone exposure, and this can actually lead to not only bone damage, but actually bone death in certain cases. And so the question is this primary or secondary? Primary is typically associated with age. It's just something that most of us will probably develop at some point as our cartilage just gets older and it becomes less thick. But you can also have secondary causes. You can have previous injuries. You can have hormonal changes. We see this a lot in older women post-menopause, where estrogen starts to decrease. You can also see this congenitally. I tell people, I see this all the time in my clinic, and my residents will attest to this, that I say you inherit your anatomy from your family, and so you inherit the good and the bad. And so if your mom or dad has low back pain or neck pain from arthritis, there's a good chance you might too. Part of that can be from genetics. Part of that could also be from the environment, especially if you do the same kind of work that your parents do. And then typically this gets worse, or the incidence goes up as we get older and as we get heavier. We see that the most commonly involved joints are the weight-bearing joints, the hips, the knees, but also the ones that we repetitively use and with our pincer and grip, specifically the hand, and specifically the thumb. You see CMC and MCP involvement as some of the most common areas of developing osteoarthritis. So how do these patients present? These patients typically have pain with activity. When they rest, they feel okay. They may have some morning stiffness, but they usually resolve fairly quickly as opposed to inflammatory arthritis. There's usually no redness. There's usually no swelling. There's often usually no synovitis, except in those with maybe erosive osteoarthritis. That being said, you can get effusions, especially in the knees, and especially if there is really, really bad meniscal tears that are leading to osteoarthritis. You can develop bony enlargement. Part of that can be from the osteophyte formation from the bone spurs. Part of that also can be from the muscle wasting around the joint that gives you sort of almost like a pseudo bony hypertrophy. But overall, sometimes it can be confused with joint swelling, but really it is just the osteophytes. On radiographs, you're going to see joint space narrowing, and that's because you're losing some of the cartilage, and then the bones, as the bones start to get closer, they may rub more. You may see sclerotic changes along the surface of the bone. You might see osteophyte formation, cortical irregularities, and actually sometimes you can actually see subchondral or subcortical cysts just underneath the joint line, and we call these geodes. When it comes to labs, there's really no labs that we typically check routinely to diagnose rheumatoid arthritis, not rheumatoid, to diagnose osteoarthritis. It is typically a clinical diagnosis, but you can use X-rays to sort of confirm your diagnosis. And if we take a look at those X-rays, if we let's say we're taking a look at the hands, what you can see here is you can see joint space narrowing along the PIPs of the hands. You can even see some subchondral or subcortical cyst formation as well. But notice that there are no erosive changes in any of these in any of these joints. You can see some significant joint space narrowing here as well along the DIPs. And those are probably the most common areas to develop it. You can also see it along the basal joint or the CMC right here as well. So these are more common areas to develop it. Taking a look at the hip here, this is an old patient of mine who had a chronic injury to her right hip. She fell down many years ago and progressively started developing worsening right hip pain, had difficulty even extending and flexing, extending the hip. And when we got an X-ray, you could see that if you compare both sides, I think that the reason I really like this X-ray is you can compare a relatively normal hip. There might be a little bit of osteoarthritis on this side, a little bit of joint space narrowing, especially towards the inferior portion of the acetabulum and the femoral head. But when you compare it to the right side, I mean, you can see there is clearly no joint space here. There's a significant amount of osteophyte formation. And this is a patient who has so much arthritis in this hip that they really can't move it at all. You know, if you're trying to do a log roll or internal external rotation, this patient's going to be in significant amount of pain. So what are the treatments? Because this is a chronic issue, we have to be very careful about what we give for these patients. You know, paramount to any of these is a good course of physical therapy. We recommend strengthening the area around the joint. Physical therapy is very useful in most of our joints. Sometimes it can be a little tough on the hips, but most other joints can tolerate physical and occupational therapy really well. When it comes to pain relief, Tylenol is probably the safest medication to give long term. You have to remember these are usually older patients with a lot of cardiac and renal comorbidities. So we have to be extra careful with long term oral NSAID use, but you can use topical NSAID. That shouldn't be a problem. There is some potential role for gabapentin as well, like these neuropathic medications for really refractory OA. And then, injections can be used as well. I think the data on corticosteroids is not great in terms of like long-term relief, but in sports medicine, we are typically using injections like corticosteroids and physical supplementation and PRP as a way to delay surgery. And so I would say that is really the role for these injections. They're not necessarily there to fix osteoarthritis. They're there to reduce the symptoms and prolong any surgical intervention. And then obviously surgery would be very much a last resort. So what I want to go over is now moving away from osteoarthritis. The next thing I want to talk about is rheumatoid arthritis, and so I like to bring up some of these athletes that have some of these rheumatic conditions. First one is Spencer O'Brien. She was a 2013 freestyle snowboarding world champion. She was a five-time X Games medalist, including a 2016 gold medalist. But she was also diagnosed with rheumatoid arthritis at age 25. And as you can see, she still ended up winning a gold medal, even with that diagnosis of rheumatoid arthritis. So even though you may have one of our chronic inflammatory diseases, people can still do quite well when treated properly. And so what is rheumatoid arthritis? It is the most common autoimmune symmetric inflammatory polyarticular arthritis. It accounts for about 20% of all arthritis, or about 1% of the population. This is typically an articular disease. This is a disease that really does manifest with synovial synovitis, synovial hypertrophy, and thickening. That being said, when this disease is not well controlled, it can start to seep out of the joint and affect other parts of the body, like the lungs, the heart, the eyes, amongst others. And often patients will develop rheumatoid arthritis actually years before they actually start to feel it. And this is typically more of an indolent process. An insidious process and then one day they sort of feel like, you know what, my joints are starting to bother me. So the etiology, we do know there is a genetic component to rheumatoid arthritis. We see this because in twins, and especially monozygotic twins, there is increased risk of developing it as opposed to fraternal twins. But even clinically and anecdotally, we see a lot of patients with mom or dad with rheumatoid arthritis that they can go on to develop it themselves. The environment can play a role, and those who smoke or have poor dentition can actually release the anti-CCP antibody, and that can increase the risk of those with rheumatoid arthritis. So we tell people if you smoke or you don't take care of your teeth, not only are you more at risk of developing rheumatoid arthritis, but your disease is probably going to be harder to treat as well because of that propagation of that antibody. Those who have low vitamin D also typically have a lower robust immune system. So those are more prone to developing our autoimmune conditions. As with most of our diseases, there is a female predominance, anywhere between 2 to 3 times compared to men. This is usually a disease considered of middle age, between the 40s and 60s, though there are some people who can develop it much, much later in life, around the 70s or 80s, though these patients typically have a much easier course when they develop it when they're older. And this is a disease that's driven by pro-inflammatory cytokines. We think of like TNF, a tumor necrosis factor, interleukin 6, interleukin 1, amongst others. So how do these patients present? Well, they develop typically a more of a symmetric type of picture. And it loves to target the small joints more than large joints. So you think of like the metacarpal phalangeal joints, the proximal interphalangeal joints. It can affect some of the large joints like the knees as well, but this predominant really loves like the hands and feet. It can be anywhere between oligoarticular to polyarticular. Morning stiffness is usually much more prolonged. We're thinking an hour or even longer, and there's almost like a gelling effect that you sort of have to break through in order to start to feel better. So these patients may wake up in the morning, get their cup of coffee, to go take a shower, drive to work, and they're still stiff, like, an hour plus later. And these patients will typically present with redness and swelling around the joint as well. And this is because you develop a pannus in that area. The issue is if that pannus is not treated, it can actually start to destroy the synovium and actually start to invade the bone and cause bone erosions that at first you might not notice. Like, it might not cause any deformity, but if it lasts long enough, it can actually start to destroy the joint. And so comparing a healthy joint to a rheumatoid joint, as you can see, the synovium, which really helps supply nutrients to the rest of the joint, it starts to be invaded with pro-inflammatory cells. This starts to wear away at the cartilage, and then once it wears away the cartilage, it'll actually start to eat away at the bone as well. Now, I'm going to show you a picture of a swollen knee. This is not a patient with rheumatoid arthritis. This is a patient actually with juvenile idiopathic arthritis, though those patients, when they're really young, can go on to develop one of our other autoimmune conditions like rheumatoid. And the reason why I show this is to show sort of the difference between a diffuse knee and a regular knee. And so in our rheumatoid patients, often it'll actually be both knees that are quite swollen. So sometimes in like younger patients, it might be really easy to see that these joints are clearly swollen. But in older patients or bigger patients, it might be more difficult to appreciate. This is where you might need an ultrasound. Or clinically, you might notice that compared to these other sports injuries, these are usually joints that are much warmer as well. So like I was saying before, the distribution of symptoms typically likes us to affect the small joints, the MCPs, the PIPs, the wrists. You can get involvement of the shoulders. Once you start getting into like the hips, you see a lot less involvement. You can even see the temporomandibular involvement in certain cases. But compared to osteoarthritis, there is a very clear distribution in the hands. As you can see in osteoarthritis, we're typically looking at the thumbs, the MCPs. Usually the CMC, the MCP should also be involved as well. But you see more distal involvement as opposed to rheumatoid, where you used to have a little bit more proximal involvement. More of the carpal bones are also involved. And then, as you can see, there's really not a lot of spinal or at least lumbar involvement in rheumatoid arthritis as there is in an osteoarthritis, though you can get cervical spine involvement, and we'll go over that in just a second. So how do these present? They can develop deformities of the hands, weakening of the extensor and flexor tendons, and this can develop boutonniere swan neck deformities. The radiocollateral ligament, for some reason, we're not sure why, becomes really weak. And then what happens is you get unopposed ulnar drift. So these patients, their hands start to drift ulnarly, and that's pretty pathognomonic for rheumatoid. If you start to see like a more of an asymmetric distribution, migrating pattern, distal involvement of their hands, low back involvement, I wouldn't really be considering rheumatoid arthritis. I may be considering either some sort of mechanical disease or some other autoimmune disease. Instead of just taking a look at some of the manifestations of rheumatoid arthritis, this is what I'm talking about when you have that sort of swan neck deformity, boutonniere deformity, the ulnar drift as well. And in some cases, you can actually get like cutaneous manifestations with rheumatoid nodules. And even on X-ray here, you can see there is sort of complete destruction of the MCPs, complete destruction of the carpal bones as well. So what is it going to look like when you're doing lab work? Well, you're going to do a CBC. You might see anemia of chronic disease, right? You might see thrombocytosis. And so these platelets might be elevated we sort of use this as an acute phase reactant. So it could be similar to like an elevated inflammatory marker. The white cells are usually pretty normal. Sometimes you can see lower white cells, like lower neutrophils, and those with Felties, which is neutropenia, rheumatoid arthritis, and splenomegaly, which is sort of a rare manifestation of RA. Chemistry should be relatively normal. Sometimes in inflammatory conditions, you can have a low albumin. ESR and CRP are typically elevated in this disease. Rheumatoid factor and CCP can be positive or not. Same with the ANA. About 30 to 50% of patients with rheumatoid arthritis will go on to develop a positive ANA as well. And if you were to actually, let's say, aspirate a joint, the things that we would look for, we would be checking cell count, crystals, gram standard culture, and we'd be looking at the appearance of the synovial fluid. An inflammatory disease, we're typically looking at more like cloudy yellow synovial fluid. And then if you were to actually get a cell count, you would see anywhere between 2,000 and 50,000 white cells. You can actually have more. When you're thinking about more than 50,000 white cells, you start to get a little bit worried about like a septic joint, though in a septic joint, you'll typically see positive cultures as well. Okay. So on imaging, what are you going to see? You're going to see marginal erosions. You're going to see periarticular osteopenia because this is not just a disease that affects the joints, it affects the entirety of the bone. It can cause atlantoaxial instability along C1 and C2, and that's because you can actually develop a little bit of pannus formation anteriorly to that joint, and that can cause a lot of instability in that area. And then you can develop these erosive changes, as soon as 3 months after, as soon as 3 months after the initiation of symptoms. On MRI and ultrasound, you can see synovitis, you can see synovial hypertrophy, you can see tenosynovitis. This is useful in those where the picture may not be so clear. Someone with a bigger body habitus, or people who, like, let's say, work with their hands for a living and may have like large hands because of that, and they think it's swollen, but you can't really tell. This is where these imaging modalities may be more useful. On X-rays, these are the sort of the marginal erosions that I was talking about. This is a destructive disease. This is not like degenerative osteoarthritis where it sort of just eats away at the joint space. This actually eats away at the bone itself. And so if you start to trend down each of these pictures, this is a patient here with very early OA. You may see some periarticular osteopenia, some with lighting of the actual bone itself. As this progresses and it's not treated, you'll start to see these erosive changes with cortical disruption and marginal erosions. And then eventually what can happen is that you can get just complete destruction and subluxation of the joints. Here you can see just total destruction of the MCPs, total destruction of the carpal bones. And as you can see, the MCPs on this hand have completely subluxed. On ultrasound, like I said, you can get synovial hypertrophy. In A here, this is what a relatively normal MCP would look like. And as you start to go into B here, you can see that this synovial space has sort of hypertrophied and sort of extended proximally. This is what happens with a swollen joint. If you were to put power Doppler on, you could see power Doppler enhancement. And then when you look at like in short and long axis, you can actually start to develop erosive changes. Ultrasound is actually a pretty good imaging modality for erosions. And as you can see, this is a person here who has erosive changes, synovial hypertrophy, synovitis. This is clearly objective evidence of inflammation. And this is one of my old patients with really poorly controlled rheumatoid arthritis when they first came into my clinic. They already had fairly obvious clinical disease in my clinic. We've got X-rays. You can see there's complete destruction of the carpal bones and complete destruction of the MCPs as well. And then if you notice, as you start to go towards the distal portions, actually the DIPs are relatively intact. Maybe a little bit of OA, but there's not that same sort of destruction as you see in the MCPs and in the carpal bones. With Atlantic axial instability, this actually can start to develop an issue with flexion because you have a pannus formation, and this can sort of push out the C1, C2. This is really important in our athletes because those who have cervical spine involvement, we worry about cervical myelopathy with manipulation of the neck or with injury of the neck. So these are patients that actually I would probably stay away from doing contact sports or collision sports because hurting your neck in these type of cases can really lead to significant disability, cervical myelopathy, and then even in really, really bad cases, quadriplegia or even worse. Looking at the ACR criteria, this is the diagnostic criteria of how to make the diagnosis of rheumatoid arthritis. We split it into sort of like the clinical domain, the serologic domain, as well as acute phase reactants and duration of disease. And as you can see, there's a clear, favoring of the number of joints and especially the small joints. If you think of 10 joints, it seems like a lot, but if you start to break it down between like the number of MCPs, the number of PIPs involved, like you could already get up to like 8 joints just within your hand. You start to include like the wrist as well. You could easily get to 10 joints before you start getting to other parts of the body. If you have 6 points or more, this is definitively rheumatoid arthritis. So if you have someone with both bilateral hand pain and swelling, you have a positive rheumatoid factor, CCP, high inflammatory markers, you can sort of clinch the diagnosis. Treatments, typically, at first, most people will start NSAIDs or prednisone. This will typically be really useful in the short term in terms of quelling the inflammation and sometimes acting as a good bridge to some of our long-term medications. We have conventional disease-modifying anti-rheumatic drugs, or DMARDs, like methotrexate, sulfasalazine, leflunomide, hydroxychloroquine. You don't necessarily need to know these medications. You just need to know that these are the medications for rheumatoid, but you don't need to know much about them. Then we have the biologics. These are the medications like the adalimumab or Humira or the etanercept or the Enbrel. These are medications that really are immunosuppressive and can really quell this disease. And then we have like the newer medications, the JAK inhibitors, the things you see on TV like the Xeljanz and the Rinvoq, which also work quite well in these diseases. From a more conservative approach, we do recommend exercise for these patients, low impact aerobic activity to minimize pain and maximize cardiovascular fitness. These patients have a higher cardiovascular burden because of the high inflammatory state that they're in. So it's really important to maximize their cardiovascular fitness. We would like to avoid contact sports, collision sports, combat sports, and those with atlantic axial instability. So if someone has RA and they have cervical spine involvement, they're not boxing. They really shouldn't be boxing. They shouldn't be doing, I would even be careful with any sort of martial art at all, but be careful with things like football, things like lacrosse, things where you could collide with another person just because of the concern for neck injuries. And then we base our recommendation in terms of their disease activity. Those who are in remission otherwise usually have no restriction. They can play as they want to. When they have more mild to moderate disease activity, we don't recommend high impact activities. We recommend more low impact. And then those who have clinically active high disease burden, maybe range of motion exercises, minimal weight bearing, rest. These are the patients that I would actually hold out from a sport until we can control their disease. Moving on from RA. If we take these athletes, you have Franklin Gutierrez, who used to play for the Indians. He was, I believe, a right fielder, center field and right field. If we take him, Phil Mickelson, and George St. Pierre, what do they all have in common? Well, they all have diseases that are considered part of the seronegative spondyloarthropathies. We have Franklin Gutierrez, who was diagnosed with axial spondyloarthritis, formerly known as ANCSPOND. We have Phil Mickelson, who has known history of psoriatic arthritis and actually was a spokesperson for Enbrel for a long time. And then George St. Pierre, who actually had to step away from the sport for a while because he had uncontrolled ulcerative colitis. So let's talk about the seronegative spondyloarthropathies. These can be split into 5 different diseases. Really, it's 4. These two are sort of the same entity in just different ways. Axial spondyloarthritis, what we used to call as ANCSPOND. Then you have non-radiographic axial spondyloarthritis, which is when the patient has the disease, but x-rays look normal. You don't have that ankylosis, but on MRI, you can see clear evidence of bony edema. This is sort of like when we're catching it early. Psoriatic arthritis with psoriatic plaques and nail changes, reactive arthritis shortly after infections, and then inflammatory bowel disease related arthritis when they have Crohn's or ulcerative colitis, but it is extended past their bowels. So typically these patients have a negative rheumatoid factor. They may have a positive HLA-B27. That is not diagnostic, but it can be associated with these diseases. Low back pain appears to be the prominent feature in this disease. That's where the spondyloarthropathies portion comes from. They can develop sacroiliitis. They typically develop more lumbar involvement, but technically can develop it anywhere along their spine. And then in terms of the extra-articular manifestations, they can develop enthesitis, where the enthesis is where the tendon attaches to the bone. That site specifically, you can have a lot of inflammation. And that's why a lot of these patients can develop nail changes because the nail bed is technically considered an enthesial site. You can develop ocular involvement with uveitis, cutaneous involvement with psoriasis, urinary involvement post-infectious, and bowel involvement with IBD. And then, so with axial spondyloarthritis, these are usually seen in younger patients. So you're talking about 20s and 30s. So this can affect very much like our athletes, like in the college and professional realm. Typically, these patients start off as low back pain, alternating buttock pain, like lateral hip pain, like glute pain. They're typically much worse in the morning, and as they move around, they start getting better and better throughout the day. They have prolonged morning stiffness, and actually, this type of back pain can actually wake them up in the middle of the night. And so if this is not treated, you can actually start developing low back pain and stiffness that can actually progress from looking at this patient over here over time, progress to significant disability and fusion of the lumbar spine, the sacroiliac joints, and where they are sort of stuck in that sort of flexion deformity. So how do we test for this? Well, we do it clinically in our office. We do what we call a modified Schober's test, where we actually measure from their PSIS down. And what we do is we measure about 5 centimeters below and 10 centimeters above the PSIS. We have them bend forward. And if there's more than 5 centimeters of movement, then we know that they have good range of motion. If they have less than 5 centimeters of movement, we know there's some sort of restriction. We do chest expansion. So we wrap a tape measure around their chest. We have them take a really deep breath in. And if there's less than 2.5 centimeters of movement, we know that there is also another restriction in their thorax and in the thoracic area. And then we do something called an occiput to wall, where we have them stand up with their heel and their occiput against the wall. And if they're not able to put their occiput against the wall, that can already tell us that there might be some sort of flexion deformity of the thoracic spine or the lumbar spine. So what do we check in these patients? Typically, we do check a rheumatoid factor and an ANA. These are typically negative. You can have a positive HLA-B27, though, and this can be present in about 90% of white patients with ink-spawn, about 50 to 80% of non-white patients, but also about 6% of the general population will have an HLA-B27 positive, and that will not go on to develop this disease. So this is not diagnostic. It's just that it can be associated with this disease. Radiographs can show sclerotic or ankylosing changes in the SI joints of the lumbar spine. MRI can show that bony edema, especially early on in the disease course. And if you're not treated, you can actually start to fuse and develop that bamboo spine. So when we look at X-rays, you can see here, you can start developing squaring of the vertebral processes. This is the like sort of the early part of ankylosis, and if you leave this unchecked, they'll actually start to become fusion of these from one to the other, and this is how you develop that bamboo spine. You develop significant flexion deformity, and actually this actually becomes high risk for fracture as you get older, and so we want to be extra careful in making sure that people don't develop this. We see a lot less of this now, especially with the invention of biologics. This is becoming sort of old news. I don't have many patients who have true ink-spawn with bamboo spines anymore because our treatments really do prevent this. And it's always good to know the difference between ankylosing spondylitis or axial spondyloarthritis versus diffuse dish. I always forget the diffuse idiopathic skeletal hyperostosis, where you can still get sort of this fusion, but it's really more these osteophytes that sort of end up developing on the anterior portion of the spine. This is not the same as this here. Okay, this is more of a degenerative process with osteoarthritis. This is actually true inflammatory arthritis. And so I like to bring up this picture of a gymnast. This is a patient that I believe Dr. Solata had actually referred to me several years ago, and was having significant like SI joint and hip pain. As you can see, it has the protrusio acetabulae, but was having significant pain along the SI joints. And so the x-rays look okay. There's not really much going on, maybe some sclerotic changes. But when we got an MRI, you can see there's clear evidence of bony edema on T1 and STIR. And so this patient was diagnosed with axial spondyloarthritis. Non-radiographic axial spondyloarthritis, was treated with adalimumab and actually had complete resolution of her symptoms. I did get an updated MRI before I had left Cleveland Clinic, and she had complete resolution of those symptoms, though I wish I'd saved it because I don't have a comparison to show you here. Moving on from axial spondyloarthritis, we'll talk about psoriatic arthritis. These are patients who have typically a psoriatic rash. they may develop more of an asymmetric inflammatory arthritis as opposed to rheumatoid, which is usually more symmetric. This is more asymmetric. Even the sacroiliitis might be more asymmetric as opposed to axial spondyloarthritis. You can develop dactylitis, or that sausage digit in the fingers of the toes. You can develop nail changes, onycholysis, pitting, hyperkeratosis, and this is sort of what it looks like. You can see that this entire digit is really, really swollen as opposed to others. And then this is like a really bad case of psoriasis, but you can develop it more along almost anywhere on the skin, but we see it more on the extensor surfaces, the elbows, the knees. Sometimes you can see it on the scalp or behind the ears. We've seen patients who also develop along their palms as well. And then when you look at the nails, this is because patients develop this with the nail bed being affected. It can actually cause to the disease of the nail as it grows out, and so you can develop pitted nails, where as if someone took a pin and just started poking holes. You can develop crumbling of the nail, hyperkeratosis, oil spots. These are patients with really like this right here is almost pathognomonic for psoriatic arthritis. And if you look at X-rays, you can see that there, like in these cases, you can see asymmetric distribution of sacroiliitis from one side to the other. You can develop this sort of pencil and cup deformity as well, which is also very pathognomonic of psoriatic arthritis, as opposed to rheumatoid, which doesn't really have this appearance of erosive change. You can even see you can see some marginal erosion here. This is like early erosive change here and here, but specifically along the IP of the first toe, uh, as opposed to rheumatoid, where you might see it more along the MTPs and more symmetrically along all the toes here. But here you can actually see maybe a little erosion here as well. And what we do is we have something called the Casper criteria. This is classification criteria. This is not diagnostic. So this is used more for research, but we do use this as sort of a surrogate to help us make the diagnosis to some degree. And as you can see, if you have active psoriasis, or you have a family history of psoriasis, you have a negative rheumatoid factor, you have nail changes, you have dactylitis, or you have like bony changes on your x-rays. These are all used as points to help in the diagnosis. If you have 3 points or more, it increases the specificity and sensitivity of the disease. I say my only problem with this is that if you have active psoriasis and a negative rheumatoid factor, technically you meet the criteria for psoriatic arthritis, even if you don't have it, even if you just have psoriasis. So there is some limited use here, but this is a good chart to show you what are the things that we are looking for when it comes to psoriatic arthritis. Moving on, we'll talk about reactive arthritis, which is sort of like a post-infectious arthritis. This happens typically anywhere between, I would say it can happen anywhere between 1 and 4 weeks. Most in real life, this is from like a textbook, most in real life, we're seeing more closer to 4 to 6 weeks. It can happen with almost any infection at all. We're seeing this also with COVID, but in the literature, you see it more with GI and GU infections. These are usually self-limiting and do quite well, but if you have a positive HLA-B27, these patients might require longer treatments. This happens in younger adults, 20 to 40 years old. When it comes to the distribution, women are more likely to develop it shortly after a GI infection, like an enteropathic infection. Men are much more likely to develop it after a urogenital infection, and that's just because men typically have more STDs or STIs than women do, and we can see this clearly associated with STI, like shortly after STIs. Prognosis is really good. Patients, even 50% of patients don't need to do anything at all, maybe just some NSAIDs or a short course of prednisone. They do quite well, and it never comes back. About 30% may have recurrent episodes, but overall they still do quite well. It's that usually the HLA-B27 positive group that may require immunosuppression and longer treatments, because sometimes their disease can be a bit finicky. So what do we do for these patients? We do physical therapy. We initiate NSAIDs. That's usually first line. If they don't respond to NSAIDs, we could go straight to biologics if they have spine involvement or like axial involvement. You can use TNF inhibitors, IL-17, 12, 23 inhibitors. If they have just isolated sacroiliitis, you can do a corticosteroid injection in that area. And if they have more peripheral symptoms, you can use some of the conventional DMARDs. But if they have axial involvement, conventional DMARDs don't work well enough. You got to go straight to biologic. And for exercise, we want to make sure that we do flexibility training. It's really, really, really important that you get thoracic extension and hip flexion exercises, because these are where patients have a big deficiency from the disease. Extension-based core strengthening is really, really important. Aerobic exercises are really important to improve chest expansion. Swimming is really wonderful for improving both thoracic extension and chest expansion. And then I would say that if you have any evidence of actual ankylosis, it might be worthwhile to avoid contact sports because the spine has an increased risk of fracture in those patients. But again, when these patients are treated and they're treated early and they don't have axial, like true axial disease, like long-term disease, they can do quite well and they can usually continue their training as needed. Moving on, next thing we're going to talk about, we have a former point guard for the Sixers, Maurice Cheeks, NBA champion, four-time NBA All-Star, retired jersey for the 76ers, and was a head coach for the 76ers and assistant coach for the Knicks. And the big thing about him is that he was diagnosed with gout at around age 46. And the reason I bring this up is when I was I think I was like in high school or college. I do remember that they mentioned it during the games on ESPN that he'd be walking around on the side of the court with his shoe off when he was having active gout flares. I do like to mention this athlete here is an Australian runner. Seems to be like noted as like the next fastest man of the world. I mentioned him here because his name is Gout. He doesn't actually have gout, but I thought it was kind of funny to bring him up here. I think he recently set a record in Australia for the 100, or at least tied the record for the 100 at 10 seconds flat. So he's an up and coming runner. I think he's like 18 or 19 years old. So something to watch out for. But I just thought it was very interesting that his name is Gout. So what is gout? It's a disorder of purine metabolism. This is high uric acid levels, hyperuricemia above 6 to 7. This can cause deposition of these monosodium uric crystals into the joint and into the periarticular tissue, like the Achilles tendon, amongst others. And then because of these crystals, it can cause synovitis and acute attacks. This can happen because of your diet. So those who drink a lot of alcohol, especially beer, like beer is like kind of the worst offender in terms of like purine load. You can also see it in those who eat a lot of red meat, especially the redder the meat, the more likely it has high purines, or shellfish as well. There are some people who just produce more purine and it can increase the risk of developing gout. There are people who also just their kidneys just don't do a very good job of getting rid of the uric acid. And then the reasons why we develop it as humans is because we lack this enzyme called uricase, which converts uric acid to allantoin. If we had this enzyme, we would never develop gout. So, like I said, why do we develop too much gout? It could be from overproduction, come from your diet, or just endogenously. But most of the time, it's usually from underexcretion. Most humans just don't do a very good job of getting rid of it. It's probably a combination of both. But if we were to put a percentage on it, about 90% of patients are actually underexcretors. So one of the few times where men are much more likely to develop it than women, especially pre-menopause. It's really unheard of for women to develop it before menopause because estrogen is so protective against that. Estrogen actually acts as a uricosuric, so it actually helps excrete some of the uric acid through the kidney. And then as women get older and undergo menopause and lose a lot of the estrogen, the risk almost becomes 1-to-1. But a lot of the other comorbidities, hypertension, obesity, hyperlipidemia, psoriasis, or those who are on organ transplants, those who drink a lot of alcohol, those who drink a lot of like sugary, like high fructose corn syrup drinks, all those things can lead to increased purine load and under excretion of the uric acid. We split into 4 stages. For a long time, patients will actually their uric acid will start to climb on their own. They won't even notice. We call this asymptomatic hyperuricemia. Then they'll develop a flare. They'll develop acute gouty arthritis. Then the flare will typically go away. Even if you don't treat it, it can actually go away on its own, and you'll be in this sort of intercritical period. The problem is that if you don't get rid of the uric acid, you'll just develop more flares, and then this intercritical period will get smaller and smaller and smaller. And then if what happens after that is that you can actually start to develop chronic tophaceous gout, where the uric acid just sort of clumps together. This can actually invade the bone and the soft tissue, and it can become a serious problem. So how do these patients present when they actually have a gout flare? It can be acute, usually monoarticular. We think of like the big toe as like the primary site, but it can technically occur in anywhere in the foot, in the knee, especially as you develop like worsening polyarticular gout. You can actually start getting it almost anywhere in the body. It can go away on its own, but again, like I said, if you don't treat it, it's going to become more frequent. It's going to start affecting more joints, and it can last longer each time. And eventually you can develop a tophus. How do we diagnose? Uric acid in and of itself, like that level, is not diagnostic. It can tell you that, hey, this patient has a higher risk, but it is not diagnostic in and of itself. X-rays, you can look for almost like these rat bite erosive changes. Ultrasound, you can actually see double contour sign where the uric acid is sort of deposited over the cartilage. Dual energy CT, you could actually quantify just how much uric acid is in the body, but there's nothing that's as diagnostic as getting synovial fluid. Like if you actually got synovial fluid, you could actually take a look at the uric acid crystals yourself. That is purely that is the gold standard for diagnosis. Histology as well, and those who undergo surgery, like if you see uric acid crystals on histology, that is also diagnostic. And then if you have like clinical evidence of tophi, that is also diagnostic. This is a couple of looks of what tophi look like. Now, as you can see here, you have deposition of this uric acid has become a sort of a granuloma here and here. And if this is not treated, eventually it can invade through the skin and sort of it can come out almost like a cottage cheese consistency. The reason why this is a really big deal is because this is very soft and actually can create a tract to the bone. So not only can you get a soft tissue infection, you actually run the risk of developing osteomyelitis, and patients can lose limbs if this is not treated correctly. Now, looking at probably the worst case I've ever seen of gout is this guy here. This is a guy with a lot of socioeconomic and mental health issues. And so for him, it was really difficult to get him the treatment that he needed throughout his lifetime over the course of years. And so this guy would come in essentially like very like in hypertensive emergency every time I would see him. Couldn't use his joints anymore. He basically lived in a gout flare at some point in his body anywhere, whether it was his knees or his feet or his hands. His hands were basically non-functional. And the issue is that he really wasn't very good at following up. He had poor transportation, wouldn't take his medication, wouldn't fill his medications. And so this is a disease that, although we think of like, we don't think it's like that big of a deal. If you leave it alone, it can actually get quite severe. And as you can see, even here, he's already developing tophaceous changes that can actually invade through to the bone, but also if it pops out of the skin, this becomes a real issue. If you look on his X-rays here, it is complete destruction of his MCPs here, but you can see cortical changes along his carpal bones, and then these sort of rat bite lesions throughout here and here and here. I mean, this is someone who really can't use his hands anymore. Moving on to ultrasound, you can see that double contour sign that I was talking about here that looks a little bit different than interface sign. Interface sign will change as you move the probe. This typically will not. Okay. And then if you do a dual energy CT, you can actually label and quantify the amount of uric acid with a color. And so most of the time it's green, but you can actually see how much deposition of uric acid is in different areas in the body, whether it's the feet, whether it's the knees or the hands or what have you. Synovial fluid, like I said, though, is the gold standard. On synovial fluid, you'll see yellow needle-shaped, negatively birefringent needle-shaped crystals. This is when you use the red compensator on polarized microscopy. If you see intracellular crystals, that means that the body is actively attacking these crystals. That is diagnostic for an acute flare. If you see extracellular crystals, that might just tell you the patient has a history of gout. Might not necessarily tell you that you have active gout. Use that in addition to checking a cell count, where if you have high white cells, like predominantly neutrophils, that could tell you that, hey, there's an active gout flare. So if you have someone who you aspirate their knee and it's not clear yellow, I would recommend sending it out for cell count, crystals, and a gram stain. And then if you're not sure if this is a septic joint or not, obviously don't inject a steroid in the area. This is what it would typically look like. So I know it's a little grainy, but this is the needle-shaped crystals under polarized microscopy. This is a patient that I actually aspirated their knee, and as you can see, there are intracellular crystals here as well. This is a patient with active gout. And how do we manage this? Baseline lifestyle changes. If you drink a lot of alcohol, maybe cut down. If you primarily drink beer, maybe switch to wine or liquor. If you drink a lot of like high fructose corn syrup, soft drinks, you maybe cut that down as well. If you eat a lot of red meat, cut that down. We don't want you. I don't want you to not live your life, but you might want to be a little bit more careful, especially if you notice that every time you eat these things or drink these things, you trigger. For acute flares, we do recommend treating them acutely with corticosteroids or NSAIDs, and then we have medications that will actually lower the uric acid. So, like I said, avoid alcohol, sugary drinks, excess red meat. We actually still encourage regular exercise when they're not having an acute flare. Make sure also that they lose some weight. Adipose tissue can increase inflammation. And then also there are some medications like diuretics, for example, that can increase the risk of developing gout flare. So it might be a good idea to either yourself or have their primary do a medication reconciliation. For acute gout flares, we'll typically use either NSAIDs, colchicine, or steroids. If it's one joint only, you could do an intra-articular steroid. The safest of all these is probably colchicine. NSAIDs can be used as well, but especially as these patients get older, you might want to be careful if the patients have cardiac or renal comorbidities. Steroids are probably the fastest acting, but be careful in those who are diabetic and those who are on systemic steroids. You have to also be careful as you wean the steroids off. Sometimes they may rebound. There are plenty of patients who have contraindications to all three of these things. And in these cases, I would say I would recommend sending to a rheumatologist so we can start IL-1 blockers like anakinra. So how do we know who to treat in terms of like beyond the flare? Like when do we actually start giving these urate-lowering therapies? Well, if the patients get more than one attack a year, that's indication. If their uric acid is above 9, that's indication. If they have renal uric acid stones, they have tophaceous gout, if they have CKD stage 2 or worse, these are all indications to start things like allopurinol or febuxostat. And the goal here is to try to get the uric acid less than 6. If they have tophaceous changes or erosive changes on their x-rays, we're more aggressive and we try to get it less than 5. This is probably, you might see more, like if you're practicing primary care, I think this is really also really important to know. And so what we do is for the urate-lowering therapies, we can use allopurinol or febuxostat. You can also use probenecid, which is a uricosuric, which helps push some of that uric acid through the urine. If those patients don't do well on those medications, or if you're unable to get their uric acid less than 9 in those cases, you can also send to rheumatology. We can actually give them an infusion of synthetic uricase called pegloticase, which is very much a last resort because this is an infusion you give every 2 weeks. They can develop antibodies to this medication. It's a bit inconvenient for patients, but this will eliminate uric acid altogether. And whenever you're playing around with uric acid, like with these medications, you got to keep something in the background to prevent flares, like low-dose colchicine, low-dose NSAIDs, or prednisone. And these are things that we'll use for about 6 months until they're completely controlled or they're at their uric acid goal. Now, comparing gout to pseudogout, gout is uric acid. Pseudogout is calcium pyrophosphate crystals. These are rhomboid, positively birefringent. These are flares that can be less painful, but this flare can take longer to hit its maximal peak, and it can also last longer in general. These patients will also have chondrocalcinosis on their X-rays. You can see it on their knees. You can see it on the TFCC of their wrist. You see this more in large joints as opposed to gout, where it affects the small joints more. So you don't really see like the large toe, for example, doesn't really get involved with pseudogout very often. As opposed to gout, where it's like you really do need a medication to reduce the chance of developing this in the future. With untreated pseudogout, it will usually go away on its own, and there's no prophylaxis or calcium lowering therapy that we use. We just sort of treat the flare as it comes up. These patients are at risk of getting pseudogout from as they get older, from primary osteoarthritis, from mechanical injuries, meniscectomies. Those who develop it in their spine may have a genetic component of developing it, but as opposed to gout and like rheumatoid arthritis, sex and obesity are not associated risk factors. It's really just more from wear and tear most of the time. And this is to take a look at the X-rays. You can see some calcium deposition along the meniscus here, and also you can see some calcium deposition here along the TFCC. This is what you would see in those with pseudogout, especially if they flare up. And sometimes their whole knee or whole hand and wrist can swell up, as with this patient. And then when we aspirated this wrist, we did see a calcium pyrophosphate crystal. It's really, really small, but you can see it's within the cell. If we zoom in a little bit more, you can clearly see that this is active pseudogout. And then that primarily takes care of most of the most of the arthritides. Moving on to some of the other rheumatic conditions, I'm not going to spend as much time on these, but I want you to be aware of these because this may cross into your practice at some point. I just wanted you to be able to recognize so that we can refer to rheumatology. Next athlete we're going to talk about is Shannon Box. She was an NCAA champion in '95 for Notre Dame. She was an Olympic gold medalist for the U.S. women's national team in '04, '08, and 2012. She was a 2005 FIFA World Player of the Year finalist, and she was diagnosed with lupus at age 30. So as you can see, again, having lupus does not necessarily mean you can't compete and do well, but it is really important to know that our athletes are not immune to developing these autoimmune conditions. Lupus is very much a chronic multi-system heterogeneous disease. It's really hard to list just one thing that lupus can cause because it can cause almost anything. It can cause like rashes on the face, like butterfly rash. It can cause alopecia. It can cause mouth sores, photosensitivity. It can cause involvement of the internal organs as well. And so really, really important to catch these patients very early. Very much a female predominant disease, 9-to-1 ratio between men and women. We really don't know why this is the case. We think that potentially the inactivation of one of the X chromosomes may lead to autoimmunity, but this is all theory. And as you can see, not just with women, but certain populations are much more at risk of developing lupus than others. As you can see, if you are a Black female, you have a 40 times risk of developing lupus as opposed to a white male. So here in South Florida, we see a lot of lupus, not just in Black people, but also in Hispanic people, because there is some genetic component to this as well. That being said, we have plenty of men who develop this. We have plenty of white people who develop this. So keep it on your radar, but especially in certain populations, I'd be much more vigilant. And like I said, butterfly rash, nasal sores, photosensitive skin, hair loss. You can develop Raynaud's where your fingers turn ghost white in the cold. You can develop serositis with pericardial effusions and pleural effusions, hemolytic anemia, proteinuria, cytopenia, psychosis, hypercoagulability, like clots. So this disease can almost do anything at once. So it's really, really important to try to catch this. In your real clinic, you might be worried about this if you see somebody with a malar rash. And so what did that look like? It sort of looks like this rash here. Sometimes it can be macular or papular, but it does cross the nasal bridge. It avoids the nasolabial fold here. And in patients with this or those with a family history, it might be worthwhile to get them in with a rheumatologist. The serologies, they may have a positive ANA, double-stranded DNA, Smith, SSA, chromatin, histone, antiphospholipid. These are all antibodies that we would typically see in those with lupus. This is the Raynaud's that I was talking about with cold exposure. The reason why this is important is in young athletes, if they play outside, especially like in the fall or in the spring, this can be quite debilitating. They may lose their grip strength, and they may not be able to coordinate, especially if they're playing field hockey or lacrosse. They might be really difficult to hold their stick. So hand warming is really, really important for these patients. Sometimes we'll even put them on a calcium channel blocker just to improve the circulation in this area. So what are the treatments for lupus? We have a lot of different medications. In the acute setting, prednisone seems to be really helpful. Hydroxychloroquine is a staple medication. But beyond that, it really depends on what their manifestations are. I include obinutuzumab here as well, because this is newly FDA approved for both lupus and lupus nephritis. But you don't need to know all these medications. Just know that in those with active lupus, they're often going to need prednisone and hydroxychloroquine. And from a conservative standpoint, we recommend exercise. We recommend protection from sun exposure, SPF 70 or more, hand warming for Raynaud's. Those with lupus, we do recommend getting a baseline echo if they're going to be involved in moderate to high intensity exercise because of the concern for pericardial effusions and pericarditis. If they're having a flare, I would avoid exercise altogether. They should be getting urinalysis every 3 to 6 months with a primary care or rheumatologist to make sure there's no kidney involvement. And then just be aware that things that stress them out, things like surgery or certain exercises, injuries, pregnancy, all these things can trigger flares. So it's really important to try to keep them stress-free the best you can. Next one I'm going to talk about is Sjogren's disease. It's very well known that Venus Williams has Sjogren's, and she has been an advocate for the treatment of Sjogren's. Most common symptoms are typically dry eyes, dry mouth, fatigue. This is a disease that when it's primarily located in the eyes and mouth, we treat very symptomatically with eye drops and sugar-free lozenges, good hydration. Sometimes we'll even do like a Schirmer's test to diagnose to see if they have obstructive dry eye, or a salivary gland biopsy, like a lip biopsy, to see if they have a lymphocytic infiltrates. But for the most part, as long as they don't have anything beyond the eyes or mouth, we typically don't treat. If they have symptoms that sound more like lupus or rheumatoid arthritis with inflammatory arthritis, these other symptoms, they usually do need to see a rheumatologist, so that way we can start them on immunosuppression. And then one of the things I like to include is polymyalgia rheumatica. Susan and I were talking about this before the lecture started, and I include this because sometimes this can be a board question. This is a patient who's typically older, constellation of shoulder and hip girdle pain or weakness, elevated ESR, and a very robust response to low-dose prednisone. This is one of the few times if they ask you on your boards for doses of prednisone, this is what they're looking for. These are patients that can be mistaken for like rotator cuff issues or glute issues, but it's typically more symmetric, so bilateral hip and knee. And then if you're concerned in this population, check an ESR and CRP. If you see that those elevated, put them on Pred 15 and send them to a rheumatologist. So the diagnosis is not that hard to make. It's the treatment. These are patients that need to be on steroids for really long periods of time. And so you increase the risk of osteoporosis. That being said, this disease can be associated with another disease called giant cell arteritis. You might remember this from your primary care days in residency. These are patients who can develop temporal headaches, visual changes, or jaw claudication. Ask those questions, because if they have those symptoms, that is a medical emergency. You got to send them to the emergency room, not just for prednisone 15, but high dose through an IV. So that covers the arthritis and the autoimmune conditions. Let's take a quick minute to talk about the therapeutic use exemption. As you can see, most of the medications that we use in rheumatology are actually completely permitted. Like there's really nothing that's banned except for probenecid. But otherwise, everything is pretty much permitted. The only thing is that you may need a therapeutic use exemption for corticosteroids if you're using oral, intravenous, or intramuscular. We're not really giving intravenous steroids to most of our athletes, but oral, like a prednisone pack or medrol dose pack, you may need to get a therapeutic use exemption. If you're using topical or doing an intra-articular one, you can do an abbreviated exemption where when you write the exemption, it's effective from when you write it. You don't necessarily need to get it approved, but this is to tell you that there are autoimmune medications can be used in these cases. And last, we'll talk about vaccinations. Really important to talk about this because our patients are, they're athletes and they're around a lot of other people and they're high risk for things like flu and COVID. For the most part, if you're on one of our medications, you can continue the medication through the flu vaccine and other non-live attenuated vaccines. The only exception is methotrexate with flu. If you are on methotrexate for things like rheumatoid arthritis or psoriatic arthritis, we typically hold methotrexate for about 2 weeks afterwards. So that way it improves the efficacy of the vaccine. It can blunt it if you continue through. And then when it comes to prednisone, typically you can give prednisone. I mean, you can give the flu vaccine, other live attenuated vaccines, and those on prednisone, except for when they're on above 20 milligrams or above, because it can blunt the response. So this is a conditional recommendation. If they have a hard time getting less than 20 and you really feel like the need to give them a vaccine, go ahead. But typically we like to wait until they're at less than 20 milligrams a day. And then when it comes to live attenuated vaccines, this is where you would absolutely send to a rheumatologist for us to try to hold their medications. Typically, we recommend holding their medication for one dosing interval for most of these. So if they're giving it once a week, we hold it 1 week before. If they're giving once a month, we hold it one month before. And then we'll usually hold it for about 4 weeks after the vaccine. And so we don't want to minimize the immune system when they're getting a live attenuated vaccine, though this is becoming less and less of an issue with this was really, we saw this more with like shingles, but now that they've developed Shingrix, we don't really see that anymore. And then, a few years ago, back when we lived in a like really COVID world, and we're kind of in that post-COVID world now, but there was a worry about developing inflammatory arthritis with COVID vaccinations. There is a rare reported side effect. Most of the time it happens usually within a week of developing the vaccine, but it can occur later. And most of the time when they develop inflammatory arthritis post-vaccination, they will resolve on its own or with a short course of NSAIDs or steroids. So before they come to rheumatology, what do you need to do? There are some labs I would recommend ordering. Check a CBC, a CMP, an ESR, CRP, rheumatoid factor, CCP, ANA, just kind of basic stuff. I would also recommend checking a hepatitis panel and a tuberculosis panel. The reason why is it kind of saves us time. If we need to start them on one of these biologics or one of these DMARDs, we need to make sure that they don't have some sort of chronic infection that we don't want to accidentally reactivate. And so that gives us a little more leeway to start these medications sooner. If you need to do something in your clinic, I recommend either starting NSAIDs or prednisone. You really can't go wrong with doing that, at least in the short term. And then I also recommend imaging the joints because you can find a lot of information there, like especially in those with inflammatory arthritis. It could point you towards like a rheumatoid or a psoriatic arthritis if they have erosive changes. And those are my references. And then open for questions. Not a great year for the Eagles this year, but we are champs. So a couple of years ago, and then I'm trying to get my daughters to be, even though we live down here in South Florida, these are going to be Eagles and Phillies fans for sure. Any questions, guys?
Can you over-treat gout with allopurinol? So if the uric acid is like at 3, should we decrease the dose?
You don't have to if they're not having a reaction. So some people can have a hypersensitivity reaction to allopurinol, and in certain populations, and this is a board question for rheumatology, but like Han's Chinese, Korean, certain Asian populations, and African Americans, there is an HLA subtype that we will check to make sure they don't develop a hypersensitivity reaction. But if their uric acid is all the way down to like 3, then you can just leave them on that dose. If you wanted to decrease it down a little bit, as long as you keep them at goal, that's all that matters. So if they have non-tophaceous, non-radiographic gout, then you can keep them less than 6. If they have tophaceous or radiographic changes, keep them less than 5. But yeah, you could technically treat all the way up to 800 milligrams of allopurinol. if you felt so inclined. And typically we'll go up 100 milligrams every 2 to 4 weeks. If they have chronic kidney disease, I'll actually even go slower. I'll go 50 milligrams every 4 weeks.
If we're doing a PPE on a patient who has like pretty stable RA, do you still typically screen for adenoaxial instability with radiographs, or is it more just based on whether they have symptoms or not?
No, I check. Like if I don't know, like if I have a patient who comes in with rheumatoid arthritis, I will typically check x-rays of their cervical spine just so I know. And if there's no atlantoaxial instability on a cervical spine x-ray and they're not complaining of neck pain, then I think they're okay. If they're complaining of neck pain and their cervical spine is the x-ray is normal, I might even get an MRI because an MRI will tell you if there's pannus formation or not. So it depends. If I know for sure that there is a cervical spine X-ray that looks normal, I won't keep checking it if they don't have any symptoms. But yeah, I would. My thing is I usually check hands, feet, and cervical spine in almost all my RA patients when they first come in.
So Heather, we had a good situation. It was interesting. A couple years ago, we did Ursuline PPEs, and everybody got through PPEs with no complaints. And then one of the stunt kids got sent in to see me for wrist and elbow pain. And she did not disclose on her physical that she had underlying RA, just failed to disclose it altogether. And the fellow who had done the physical didn't do joint range of motion fully. And I can say that pretty confidently because the kid had virtually no wrist extension and could not supinate even at the elbows to neutral on both arms. And she was in stunt. And she presented after a fall, and the athletic trainer was pretty positive that she had had an injury because her range of motion was so restricted. But if you checked her other arm, you saw her range of motion was also very restricted. And she still completely denied having any medical issues. And then I x-rayed both forearms and wrists and hands, and she had like unbelievable joint destruction for a kid who was like 19 years old. And if you opened her Epic chart, you could see she had a long-standing history of a relationship with a rheumatologist, and she hadn't reported it at her physical. So I always tell people, it seems really stupid to do, forearm, wrist, hand range of motion at the time of your sports PPE, but you're talking about a kid in stunt who was literally trying to use these forearms for tumbling, and for stunting and holding people up. So you can imagine how well that went. So I think it's a good learning point to remember, like some of these kids, you got to really be careful. They're going to lie on their PPEs, especially at the college level. We've had some pretty scary underlying medical conditions go through because people lie. And just making sure you're really checking all joint range of motion and doing inspection and looking for any swelling or obvious deformities, because even in this age range, we will find stuff.
Yeah, it's really, really important. I mean, like you said, these kids, they will, if there's any chance that you might hold them back for a chronic disease, they will typically lie about it, or they'll lie about their treatment because they don't want there to be any chance that they won't compete. And so with these patients, if they had active, rheumatoid arthritis, they wouldn't compete until their flare had resolved. And then it becomes an issue of like if they have severe joint deformities, it does become a question of like, well, they're high risk for fracture now. If their wrists and elbows are completely destroyed, yeah, you'd have to be extra careful in these sort of contact sports or like tumbling, for example. I mean, they could really injure themselves. So yeah, be extra cautious if something doesn't look right. Don't skimp on your PP on PPE. Like do a full thorough exam because that's going to serve as your baseline also. If you do a poor job of your PPE, then it becomes the downstream effect is for the rest of you don't really know. You're always gonna go back to this original baseline that's not true. These are good questions. And any other questions?
As always, thank you for your time. I know it's a long talk, but it's like super useful, I think, for all of us thinking about things clinically.
Of course. Again, like I said, these are things that will come into your clinic. Like it's really important for you to recognize it. Like I said, you don't have to treat these patients with methotrexate or these biologics, but you need to at least recognize them to know that hey, this is not an acute sports injury, or this is an acute sports injury on top of somebody with an underlying autoimmune condition. It's going to be treated a little bit differently than your typical injuries. So it's got to be like a multidisciplinary effort to try to get these patients back on the field or back on the court. Okay.
You gonna
And
be at AMSSM?
I'll be there.
Sweet.
I'll be there. Listen, if you guys have questions, like what invariably happens is that after we get off this call, the people will have questions. Like I'm always like that too. Is after the fact I always have a question. Susan, if you want to give them my email or my
Yep.
number, they can always send those questions to me, and I'm more than happy to help.
Yep, absolutely. And his email is on the email that went out for the reminder for the lecture this week too. So
Yeah,
if you
you
can't
can
find
send
it,
me.
just holler at me and I'll send it along.
Awesome. As
Thank
always,
you.
I'm really
Have
really love this is one of my favorite talks. I'm always happy to give this talk. So if you ever need me, you know where to
greatly
find me.
appreciate it.
Awesome. Thank you very much. Thank you for having me.
Yep,
Thank you.
always.
Take
Bye.
care.
Thank you.